This conference will now be recorded.
Evening, everybody. It's March the 3rd. Rick Davis. I am moderating tonight. I forgot to tell everybody before they started. I think we only have one new gent who didn't know this, but we do record these meetings. But this gent knows we record them because he's actually watched us on the recording, so he knows this part. And you can change your name, you can be anonymous, you can do anything you want. We want to make it as easy as you can for you, but we do record these groups, one, so that people can come back and listen who are in the meeting, and two, people like Mike W can join us in person and ask their own questions after they've seen what goes on the recording. And so we're very, very glad to welcome you. Thank you to our sponsors, who are Johnson & Johnson, Bayer, Myriad, Telix, Blue Earth, Foundation Medicine, and one more that somebody else will remind me, but I know there's one more. Thank you, Novartis. Thank you very much. We are hopeful that we will get Pfizer back in the fold before too long as well. So we will see. We have one new gent, and he knows the routine because he's seen it all before. So we will start with him. I don't think I've got anything else really important to bring to everyone's attention. So let's get going. All right. Mike Wilmot. Hello.
Hello.
How old are you, sir?
I am 75, to be
Yes.
76 in June.
Okay. So, where do you live?
Bakersfield, California.
Oh, yes. We know where that is. And when were you first diagnosed?
2015.
Okay. I guess I should ask you, how did you come to find us on YouTube?
I don't know. Well, I know I found you on YouTube after I found the AnCan site, but I don't know really what I clicked, where I was when I clicked a link to AnCan. So it's on the internet, so I can say that.
Don't worry. We're just glad you're here. And have you signed up for a reminder?
I thought I had, but I didn't get one, so I'm thinking maybe I didn't.
Okay, well, if you would be kind enough, the chat window are the two little boxes at the top right next to where it says 37. And if you be good enough you can send it to me, or if you want to send it to everybody, because they're a pretty friendly bunch and they'll reach out to you, you can send it to everybody. But if you'd be kind enough to put your email address in there, I can check it later on and make sure that you do get the reminder going forward.
Okay, I'm on my tablet right now, but I'll get on the computer and get that window. I don't see the little window you're talking about. So.
Oh, okay. Yeah, I know that on the tablet things do show up differently. For good order's sake, I'll put my email in the chat. Okay. So the chat's quite useful, by the way, because the people really use it in this group, and they will put a lot of good resources in there. So it's sort of good to follow what's going on in the chat window. So you were first diagnosed in 2015, and at that time, do you recall what your Gleason score was and your PSA level?
I don't recall the PSA very well. I think it was about 9, but I'm not positive at all. It was a primary care, yeah, that ordered the test for PSA. The same PCP office the year before had said, "Oh no, no, we're not running PSA tests on you guys." So he didn't run one. I was with him for 2 years, and then when he left, they got somebody new, and they said, "Oh yeah, let's get you one." So it depends on your doctors, I guess.
And what was your Gleason score?
Oh, the Gleason score was 7, 4 plus 3.
Okay. And so at the time, by my reckoning, you were probably around 65. And how did you proceed? With what type of doctor and where?
Okay. The PCP sent me to a urologist. He kind of explained what should go on. I didn't like him at all. And so I realized that I was going to make some decisions about radiation or surgery. And I decided on surgery and decided that the Oregon Health Sciences Hospital probably would have the better people. So I got an appointment up there with a doctor. I can't remember her name. She did the samples and asked me if I wanted to do surgery. She said, "You really should, but it's up to you." I had researched the seeds thing before and wasn't too thrilled with that. So I okayed the surgery and she did it. It's the Da Vinci thing. And I got to admit, after listening to the people on the YouTube channels, you guys know a whole lot more about your care than I know about mine. I just kind of just followed whatever I was told to do and did it. But I'm getting better now.
So
anyway, after that, go ahead.
I'm curious why you went all the way up to OHSU when you could have gone to either UCSF or to UCLA.
Oh, and at the time I was living in Oregon.
Oh, who knew?
Right.
Okay, now it makes sense. All right, got it.
Yeah, I figured they'd have the best in the state anyway. And I may have been wrong. You never know. But that's where I ended up.
Did you have any scans before they did the surgery? And what were the results of those scans if you did?
See, here's where I don't know anything. I just don't know what they did. Yeah.
Okay. And what was the result of that first treatment, that first surgery? When did you have the surgery? 2015?
Yes, 2015. I can't remember the date, but it was probably, oh no, I did. The procedure was on my birthday. So it was June 19th.
Oh, there you go. What a birthday present.
Yeah.
And what happened after you had the surgery?
After the surgery, I went back, called to get an appointment to see her again, and she was gone. I just disappeared someplace. So I thought, as long as I'm going to be getting a new urologist, I'll get one in town. And the guy I went to first in town said, "No, I'm not going to follow you." So I looked around, and there's a Samaritan Cancer Center in Corvallis. And I went over there and found a urologist, and then they referred me to a radiation oncologist. And I guess my PSA had dropped, but it was still at 0.12, 0.13 along in there. And they said it should have gone to 0, but it didn't. So they recommended adjuvant therapy, radiation therapy. There we go. And so we did that. I don't know exactly how many times, but around 40 treatments. And that was all completed by Thanksgiving of that year. And
but the bigger question is, do you know what they radiated when they did that?
Yeah, it was just I don't know exactly. They said it was the prostate bed.
Okay.
I don't know if they were focused indirectly on it or if they did the whole hip.
Okay. That makes sense. And then, so this was like, now we're turning across to over to 2016. And what's happened since 2016?
PSA never went to zero. So it's just been climbing from the 1.2 in over the years. Well, no, the urologist I had prescribed some medication for me, and I don't know what it was, but it killed my brain. I just couldn't think, couldn't make appointments, would show up on the wrong day. And I told him I couldn't do that. So he let me quit taking it and we'll just follow your PSA. So we did that for, let's see, I moved to California in 2017. So they followed it a few times up there. And then down here, I got a new PCP and he said, you need to get over and get a medical oncologist. And so I went to it's called AIS Cancer Center. And yeah, Dr. Solis was the medical oncologist. And then Dr. somebody else was the radiation oncologist. And they wanted to get me on Lupron. And I told them, no, I couldn't do that. I'll have to retire if I do that. And I didn't want to retire. So they just followed and followed and followed. And along the way, it got up to around 5, a PSA of 5, I think again. I was back up to 5. And I was on disability at work.
Let me interrupt you just to fill in a couple of holes here.
Sure.
I mean, it sounds like whatever that first drug was that you couldn't deal with was also some type of LHRH or Lupron type drug.
Yeah.
And they took you off. And when did you move to Bakersfield from Oregon?
March 2017.
Okay. And then you said that you found a local general medical oncologist. What year was that?
That was 2017, maybe a little bit later. I don't know, later in the year.
Okay, I mean that's good. That's close enough for us. And so they recommended that you go back on an LHRH drug or maybe more, and you said you didn't want to. And then your PSA was at 5. And what year was your PSA at 5?
This year, 2025 or
So
2024.
Okay, so it's crept up, and that's the highest it's ever been.
Yes,
And you're not on treatment.
I am now. Started with Lupron in June.
Okay. Now,
got a what is it? A 3-month shot, and my PSA went to 0.
and did they give you a drug before they gave you the Lupron?
No.
Yeah. So again, that's an error. You got away with it, but that's an error. It's not practice. What about a PSMA scan? Did they do a PSMA scan?
They did, yes. No, it was. They did that before they put me on Lupron. They did the PSMA scan. It showed 5 active spots, but they weren't very big, and they acted like they may not really be cancer. There might be something else that shined out. But anyway, I went on the Lupron. 6 months later, PSA was nearly 0, and they did another PSMA scan, and they couldn't find those spots anymore.
Okay, so they did a second PSMA and those spots had disappeared. There was never
Right.
any discussion about radiation to go after those spots.
No.
Okay.
And I have talked to the radiation oncologist since I started on this stuff, and he said, "Well, you know, I might have done something, but I can't do it now because
right,
I can't
right.
see what I do."
That's right. That's right. I mean, that discussion should have been. Now you're on Lupron. Any other drugs?
For cancer, no.
Okay. Well, and have you had any type of genetic or genomic testing?
I did have a genetic test. It's got about a month ago, and I think they tested 63 or 80 some areas, and had nothing in all of them.
Okay, so that was to see if you had anything inherited, correct?
Correct.
Okay. So they never sent before when your blood level was at 5 before they started the Lupron, they didn't send that away for analysis?
No.
No. Well, a bunch of stuff here. There's a lot of what we would call standard of care that are recommended by the guidelines that your medical oncologists are not following. It's not surprising. You know, in Bakersfield, it's not the greatest. I know UCSF has reached out a number of times, and they do have some docs that travel out to Bakersfield. They have some people from the urinary group who go out there to try and provide care, but this is far from the best care. At the same time, seems to be working for you. My biggest concern is that you're not on a second line anti-androgen right now, which you probably need to be. And so, what are your questions for us? I should ask you that first.
The first
Because advice is only worth what you pay for it. And so far, you haven't paid us anything. And I'm sitting here and telling you what we think or what I would do. And you haven't even asked me. So, you know, you could go tell me to take a hike.
No, I won't do that. I came to talk to you.
Okay.
So, first question I had after listening to a couple of your things was you kept talking about genitourinary oncologist. And I looked around, the nearest ones I could find were in San Francisco or down in LA and San Diego.
Yeah.
So I'm wondering, is that something I need to track down, or am I too far committed to what I'm doing?
Okay, well, we'll throw this open to everybody, but I'll answer that. You are absolutely not too far down. And yes, you do need to get one on board. And if you tell me your preference, whether you prefer to go to UCLA or UCSF, we can recommend one or more doctors at both places.
Okay, probably UCLA then. And again,
Matt,
I want your opinion, your advice.
Okay.
If it's smarter to go to UCSF, I'll drive a little further.
No, I mean, I think the docs in both places are really good. We get very good feedback on Matthew Reddick. People really do seem to like him. He's a great doc. He knows AnCan, and I would start off with Dr. Reddick at UCLA. And I think he'll get you onto the right meds, which is the first step. And if you are, how are you handling the Lupron this time around?
Doing good. I still have the fatigue, and in the last 6-7 months, I've lost a lot of muscle out of my legs, So I'm trying to build it back now, but it's a little exercise, but I'm unable to walk more than about a mile a day. It'll come back. I mean, 2 years ago, I was walking 7 miles a day. So,
well, you know, hopefully we'll get you back there, but I think Dr. Reddig is the man to talk to, and he's also empathetic to playing around to get the best fit on hormone therapy for you. Herb C is not with us today, but he got a much better regimen, HT regimen, than he did locally when he went to see Reddick. So if you feel that you're getting beaten up by the Lupron, that's it's a good thing to tell him. Hold on a minute. I'm gonna put his name in that chat window, which I don't know if I can't help you figure out how to find the chat window on a tablet, I'm afraid.
right.
Somebody else. Jeff Marchi, how do you find
upper right corner? There's a little gear, and right next to that is a couple of little square windows. That's the chat.
Okay, got it. Found it.
Okay.
So I just put and if you click on that, it'll open up. If you click on this link that I just posted, it'll open it up on your tablet. You can look at it later. There's also ways to download the chat, but we'll leave that for now. But we would say Dr. Matthew Reddick. Anybody here right now seeing Dr. Reddick? I don't think there is. Oh, there you go. Yes. Brian, what do you got to say about Dr. Reddick?
Can you hear me?
Yes.
Yes, I can.
I could say that he was the best thing that ever happened to me in my treatment course. Yeah. So, and I learned about him from this group. And like you, Mike, I kind of live out in the sticks. I'm in Idaho, small suburb, small town, about 30 minutes outside of Boise. So I get all my lab work done locally, but any scans, anything of importance I have done at UCLA, and I have friends and family down there, so it makes it easy for me to fly into LAX from Boise.
Yeah.
So I would say all your lab work, stuff like that, have done locally. Even a DEXA scan, have done locally. But when it comes to PSMA, PET, CT, blah, 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 Dr. Reddick is your man. So I have nothing but great things to say about him. And all you need to do is one visit, one mano-a-mano visit. After that, he'll see you on a Zoom call or whatever. You don't have to fly down. So he'll follow you, but he'll do it through a Zoom meeting. But there has to be that first contact,
Sure.
physical contact, and then you don't have to fly down there. Other than my recommendation is any serious testing.
Yeah.
Brian,
Diagnostic testing.
Yeah.
There you go.
I'd agree with Brian. You're better off getting your diagnostics down there. But I will just say one other thing. You may be able to even get, because there's a difference between you and Brian. You live in California. So I don't know, but you might even be able to get that initial visit through Zoom. I don't know.
Huh?
But when you live out of state, they sort of need to see you in state first. I don't know. I could be wrong, but I would at least inquire. At the same time, I would probably say you're better off driving down there. It's not that far from Bakersfield, and you don't have to worry about snow on the Grapevine. So go on down there. Who else has got something that they would like to say to Mike? Dr. John.
Mike, Brian mentioned something in passing, DEXA scans. When we take drugs like Lupron, it can thin our bones. And so it's good to have a scan to see the quality of the mineralization of your bones, as well as maybe a testosterone level, because in the future, maybe every 2 years or so, you can get a repeat and make sure your bones don't get too thin. DEXA, you can bring that up when you see Dr. Reddick, and they'll probably order you one.
Okay.
I
I know
wanted
I've
to
had one
also
before,
ask
but
you.
I don't know what it said.
Okay. I was going to also ask you if that very first medicine that you were on that fogged your brain, was that given by shots or pills?
Pill.
Okay. So not Lupron.
Oh, well, no, but it wouldn't have been Orgovix because that was back in what year was that? That was
Yeah,
2018.
2015.
Yeah, I don't know what, unless you had a bad reaction to the bicalutamide, which is possible, but I don't know.
Yeah. Well, it doesn't matter now. I've retired, and I can watch
Okay, so
TV and read.
right, you don't have to, now you're retired, you don't have to think straight, right? Now I
Right.
do have another question for you before I go to Brian. After they did the surgery back in 2015, did they tell you that your Gleason score had changed?
They didn't, and I don't know. It sounds like that happens to people, but I don't know what happened to the samples afterwards. If they did it and didn't tell me, or didn't do it.
I think it's really important to find that out because it sounds like because your disease came back so quickly that it's somewhat aggressive. At the same time, it hasn't grown that quickly. So that's really comforting that with minimal treatment, you're only at a PSA of 5 after 10 years. But it really would be helpful to write to OHSU and ask them for a complete copy of your medical records.
Yeah, okay.
Especially since you're a little foggy on it yourself. I think it would help you. It would help Dr. Reddick. It would stand you in good stead going forward.
Sounds good. I can do that.
Anybody, Brian, did you have something else you wanted to say?
Well, not really, other than do all your lab work locally and have it done at the same lab. That would be my advice. Don't take all the variables out. And Rick, you might be right. If you live in California, you may get a hall pass. I don't know, but I definitely would have all my scanning, like PSMA PETs and anything else they want you to do. I had short or SBRT for 3 lymph nodes. 5 is, I think, the cutoff for SBRT, although I could be wrong on that. I wonder if you might take you off of Lupron and try to identify those lymph nodes that were hot and go in and try to radiate them, spot radiate them. I don't know, but Reddick is the man, thanks to Rick. And he is taking new patients, so I think you're in really good shape.
Good. Sounds good.
Okay. Well,
Welcome.
look. Welcome. Yes. Thank you, Dr. John. Welcome. Please make sure we have your email so that we can reach you. Len, did you want to add anything?
No, you kind of covered what I was going to ask about, Rick. I was thinking that maybe he had taken bicalutamide or even Abby, and that's where he got the brain fog from. Although it would have been unusual back in 2015 for a doc to give Abby without any anesthesia.
Yeah. So that early in the process, it hadn't really been accepted as earlier on.
Right.
So yeah. Okay. Thank you. I can see your email. That's wonderful. We'll make a note. I'll make sure you are in. And I think that we will move on to hit the question list because there's a couple of really interesting things, discussions that we might be able to have tonight. So, me go back to my list here, and we will start with Mark Valens, and then we'll go to Mark Baldridge because those were the early birds.
I just have a quick question about nausea. I didn't have any from chemo, and I didn't for the first 2 weeks of Pluvicto, but now 2 weeks later, I'm getting it. Is that possible that it would take that long to come on, or is the nausea maybe coming from something else? Does anybody know?
Frank, why don't you take? Yeah, you've done all of this, so you the man.
So nausea, I'm going for Pluvicto right now too. I got my 5th treatment coming up next Tuesday. But anyway, the nausea is like the worst part. But I don't throw up. It's just retching. I retch so hard that I blew a blood vessel in my eye. But so they have the medicine for like I don't know what the name of it is for the upset stomach. But the one that works for me best is the one that I put under my tongue. I could ask my wife the name of the medicine.
Well, they've actually prescribed me a couple. I just was surprised because I didn't react for 2 weeks.
Yeah, I was the same way.
Oh, okay.
Yeah, so but yeah,
Okay,
so, I mean, go ahead.
Well, then maybe it is just the Pluvicto. I thought I was getting away without any after 2 weeks doing just fine, but
Yeah, it's tough. But the best thing to do is to get ahead of it. Like before my treatment, I start taking. I always drink a lot of water every day. But I get ahead of it by taking the nausea medicine. I take it like stool softeners. I'm eating Activia. I mean, I'm keeping my gut as in the best shape I can. And then, because it's hard to eat when you get the Pluvicto. I have no appetite, and I don't even want to drink anything. But you gotta stay ahead of that. You gotta fight through it, and it only lasts 5 days, and you're good. I mean, so it's worth it. I mean, for me, the Pluvicto is working. So I don't know what your situation is, but anyway, that's what I'd say. Just stay ahead of it.
okay.
If you understand what I mean. Yeah. All right,
Dr.
cool.
John, do you have any input on this nausea stuff?
I suppose the pill you're taking is ondansetron. Do you know? Does that sound familiar?
Well, that's one of them, and that one gives me really bad constipation. And but there's another one with a C.
Okay,
And
so they're trying
Compazine?
different ones.
Is it compazine, Mark?
yes, compazine.
Good, man.
And that didn't help? That's a pretty good one.
Well, no, my experience with the chemo, they had me take it, but I never got nausea, so I stopped taking it. And so the same thing with the Pluvicto. I didn't take it. I wanted to see what would happen, and like I said, I went for 2 weeks without any problem. But maybe I do need to take it. I just I wonder what else. It could be something else too.
So, Mark, here's what I'm going to suggest to you. Okay, write to Dr. Rahul and ask him. You can self-refer, but you may as well go through him. Ask him for a referral to the UCSF Symptom Management Service, SMS, Symptom Management Service. That's their palliative care peeps.
Okay.
They are really good. I mean, they are, in my view, they're one of the best palliative services in the country, along with MSKCC. They're really, really, really good. I mean, if you can get an appointment with Mike Rabo, that would be fantastic. He knows us. He knows me, Rabow, but I think he's the chief.
I tried to get in with him on another issue 2 months ago, and he said he's just totally booked full. He can't
Yeah.
take it.
But they're all good there. Even if it's not a doc, even the nurse practitioner, and I don't often say this, but even the nurse practitioners are really good in that symptom management service. Get yourself an appointment with the symptom management service, and play around with them, and we've got Compazine, on Dancitron, Zofran, which is the one I'm most familiar with. Is Zofran the same as on Dancitron, Len?
Yes.
It is, isn't it? Yes. So, and see what they do. The other thing is, and you can try. Have you tried ginger? Have you tried using ginger yet?
I did back when I started the chemo, but I don't think the chemo ever caused any.
Okay,
I haven't tried it with the Pluvicto.
And something I read, I put it in. I've actually got it right here on my desk. No, that's not the one. You can make a tea with the ginger. Get some fresh ginger. They suggest mixing it with a little orange juice or fresh orange juice and a little honey, and let it steep. And the medical reasons are because the ginger acts on the nausea receptor in the brain. And so it for some people it works really well.
Okay.
Another thing is they have those ginger chews at Trader Joe's. So you can get a couple of packets of them and just try sort of sucking one of those ginger chews. But the ginger can really work for a lot of people, and it's mild and it's homeopathic.
I'm sure Ann has some in the kitchen. I just got to go find it.
Yeah. Okay. You get that Ann V on the job. Okay.
Okay. Thanks, guys. I think that's all the help I need.
Okay. Mark Baldridge.
Hi, everyone. I have two questions, and they're closely related. So
Mark and Kathy, excuse me, Mark and Kathy Baldridge. Excuse me, Miss Kathy.
My better half, yes. So 3 months ago, I had a PSA test, and it was 0.03, barely detectable. This last week, I had a PSA test, and it's 0.10, and my testosterone is 137. My GU medical oncologist said that she wants to wait until my PSA is 0.2 before having a PSMA PET scan. And my question is it sometimes better to wait until my PSA is like 0.3, 0.4, 0.5, in the hope that there'll be more potential lesions showing up compared to like at 0.2, maybe a lesion or two might not be discovered because the PSA is so low?
Well, there's another school of thought attributable to Dr. D'Amico and others that we should be watching out from 0.1. So I would, don't you see Heather Cheng? Is that right?
Yes.
I'll send you the article, and I would pass this article along to her.
Okay.
Because this was specifically written for some of these docs who are reluctant to step in. Might you see more? You might. But if there's something there and we don't see it, then we'll just repeat it.
Okay.
but D'Amico wrote this piece. I can probably I know I can find it, and I'll try and put it in the chat window for you, and then I can send it to you later. But I would say that if it's gone, well, first of all, I'd probably get another test in a week or 10 days to confirm.
Okay.
I think that would be my first response. If it was still up at that level, then I'd present this to her and say, well, do you think we should go in and look now? Len, what are you thinking?
Yeah, Rick, I'm thinking that the paper you're thinking of by D'Amico was specific to post-prostatectomy, when to pull the trigger for salvage radiation therapy. I think that's the one you're talking about. I don't know Mark's history. What have you had so far, Mark?
I have had a prostatectomy and then salvage radiation of my pelvic and lymph nodes.
Yeah, I think
and then I had, yes, and SBRT. I've had 2 lesions that I had SBRT.
Yeah. So Rick, I'm not sure the D'Amico article. If I'm thinking,
no, you're right.
Thinking,
you're right.
Yeah.
You're right.
Right. Okay.
So what would you do? What if it were you, Len? What would you do? Would you wait? Would you not wait?
I think you could afford to wait. You're at 0.1 now.
Yes.
0.2. It's not as if your cancer is going to be running rapid. It's still eminently treatable at 0.2. And like you say, you're more likely to pick up possibly more lesions or any lesions. At 0.1, you may not pick up anything. So that would, I think I would wait, but that's me.
Okay, so 0.2 sounds reasonable. I mean,
to do a PSMA.
To do the PSMA.
Or we were wondering if you should wait till it's like 0.5, because the percentages of detection go up as the PSI rises. We've seen some figures.
Yeah, but you can always repeat the test. If it were me, I would not. I definitely would not.
Okay.
You do it at 0.2.
Yeah.
I do it once I get over 0.15. I do it. I mean, if that's where he thinks it's important for salvage therapy, I would say that's where it's important in most cases. Although, I mean, I've put the paper in there. You can definitely read the paper. Or actually, this is the reference to the MedPage Today article. I've also got the paper here, and there's a reference within that to the ASCO article. And that's what I would do. I mean, I'd rather know what was there if it's going to be there sooner rather than later. That's the way I would approach it. But
okay.
I don't disagree. Len's more evidence-based than I am. I mean, I'm evidence-based, but not as much as Len is.
Thank you.
You had a second question.
Yeah, my second question is, last time I had...
Hold on before your second question. Does anybody else want to comment on what they might do, or what have they had to do it? We have a couple of hands up, so maybe we got some peer experience here that could be helpful. Luther, start with you. Luther? Speak up, man. No, you're off. Now you're muted. Unmute. Okay, we'll come back to you. Jeff Wood, what about you?
At the time that I got it, the recommendation was like 0.5. And I know now, 0.2 is reasonable time to do it, that's for sure. But how many times will insurance let you do it? in a year? Or
I think it depends on your doc. You know, I mean, if your doc can justify it, then they'll let you do it. Now, if Dr. Chang isn't very keen to do it under point two, you may have to wait till point two because that's what she wants, and you're not going to be able to get much beyond that, even with the evidence of the D'Amico paper, which, as Len points out, isn't exactly on point, but it's kind of relative. But you know, if you don't see anything, then they're going to have a good argument to say, well, let's look at it later on.
Yeah, that makes sense.
All right, is my mic working?
Yes.
Had to go get the headset. I had an extended conversation with my med oncologist since I was a low PSA guy, and he reiterated how bad of an anchor it can be. Some guys can be very high, some very low. Why wouldn't you get the PSMA sooner? My PSMA or PSA after surgery was 0.2, and I had 3 lymph nodes that needed to be radiated. So, you know, you can have multiple lymph nodes even with a low PSA score.
Yeah.
Yeah. Good point.
That's a good point. Thank you for sharing that.
Yeah. Thanks, guys. I mean, this, you know, you've heard me say it so many times, but there's no better advice than peer advice, because these guys have been through it, and not everybody's the same. And we don't know. Mark, were you a low PSA guy? I can't remember.
Yes.
Yes. 4.4 when I had my highest ever was 4.8.
Yeah. So, you know, use that argument with Dr. Chang and say, but I've always been a low PSA guy. And, you know, and I got another guy at OHSU who's a low PSA guy, and they went in and found something. So she's reasonable. She'll listen to you. She's not going to throw you out for disagreeing with her. And she's maybe even going to respect you more when you come back and say, but this is a peer, and here's what Dr. D'Amico said, and see. For me, if you don't see anything, you just go back and you do it. But then probably you would wait till you were about 0.4 or 0.5. If you don't see anything now, then probably you wait till you're 0.4 or 0.5.
Okay, thank you. That seems like great advice.
Now, what's your second question?
My second question is, let's just say the PSMA PET scan, let's just say there's a couple lesions, and then we decide to do SBRT like I did before. My question is, like, is ADT necessary at that point? Or do we just play like whack-a-mole with the PSMA PET scans and the SBRT? You know, in the back of my mind, it's always, I've had a total of 24 months of ADT. In the back of my mind, it's like, well, ADT is only going to last for a certain amount of time before my cancer is resistant to not having testosterone. So that's my question. Your thoughts about ADT? If it's really necessary this next time around.
Who wants to take that one on first? Which one of my experts wants to take the whack-a-mole without ADT? Len's volunteering. Go ahead, Len.
My understanding is that if you're going to have metastasis-directed therapy for lymph nodes, that you have to hit them all, or it's not worth doing. You can't, if you have 5 and you only hit 3, there's no evidence that that does any better than not doing it at all. So if you hit them all, it's a good strategy.
Okay.
But do you need ADT with that?
But even the ADT, doesn't that just kind of put the cancer in a state of dormancy? So
it's not cytotoxic.
The question you're asking, though, is the second time around. You've taken 2 years of ADT. You've had radiation in the past. Now you're going to have possibly SBRT and you're wondering whether or not you need to do the ADT all over again. And that's a good question. I'm trying to figure it out as you're talking about it. I don't have an answer to that. And Glenn, anybody yet? John or Rick? I mean, if I go on a vacation, holiday, which I'm hoping to do, and I get a recurrence, which I'll probably most likely have, do I have to go back on the ADT or can I get the spot therapy without it?
You know, I tend to think, you know, I sort of say it's kind of like a baseball game. What do they say? Fielder's choice. You know, different physicians do this different ways. I don't know that there's a right and a wrong. Jeff Marchi, is there a right and a wrong?
Well, I think at the point that he's at, that he's had recurrence, and they put him on abiraterone or darolutamide. I mean, abiraterone would be the first thing unless he's got heart issues. But if that's the direction I went when I was at the position he's in right now, and I know a lot of other people, when you have metastasis and you're starting to have your PSA rise again with just ADT on, I mean, that's usually what happens. They put you on Abby or one of the lutamides.
Brian.
What was your Gleason score, Mark?
It was 4+5.
Well, then I'd be on the side of augmenting with ADT.
Okay.
Brian, go ahead.
Thanks, Rick. Mark, did you say that you see a genitourinary medical oncologist?
I do, yeah. Dr. Chang at Fred Hutch. Yeah.
Okay. So I saw Dr. Rettig at UCLA. His name was brought up earlier. They had me, they did a CT, PSMA PET CT twice until we found the Mets. Once we found them, we mapped them for SBRT, but immediately started me on ADT drugs and the doublet therapy. So I started on Eligard, which is the shot, and my testosterone went up. So they switched me over to Orgovix, and then my testosterone just, went undetectable. But they added the doublet therapy, which is, for me, it was the enzalutamide, also called Xtandi. And even in the presence of a normal testosterone, I mean, my testosterone went up. My PSA fell like a sack of cement. It went from nearly 20 to 1.4 in the presence of testosterone of 488.
Wow.
So that second line.
Okay.
Listen, I don't think there's an answer. Like Brian just threw his hands up in the air. I don't know. I certainly very much like Dr. John's point. You were a 4+5. That's got to be a factor. There's a lot of issues going on here. Dr.
Brian's
Chang,
mic went out. That's why he threw his hands up. He couldn't get the last few words out.
Thanks, Jeff. So, I think you have a great GU med onc in Dr. Chang. I think you've got to rely on her.
Yeah, I think so. I'm happy with her. Yes.
Peter Monaco, we've got you on 3 times, I think, at least twice. So we've got to get rid of you on one of them because we're getting a bit of some feedback. I'm going to throw you out on one. Hopefully you'll still be here.
I haven't.
Okay.
I don't know if you can hear me. I'm trouble with the system tonight.
Yeah, we can hear you. So we've only got you in once now. Dr. John or Len, would one of you please start helping Richard Cramond? Because I have to run in and shut my oven off. Otherwise, my sauce is going to be boiled down to a pesto. Okay.
I forgot completely about your sauce.
Yes. It's lucky someone remembered, isn't it? Hey, listen, I got two Italians here co-moderating with me, both of whom cook, so both of whom get it. Okay, I'll be right back.
Take care of that sauce. All right, John, you want it?
Yeah, where were we? Richard Cramen?
Yeah.
Yeah.
I've got just a question of what I can expect. I had a blocked, I had urinary retention. So I went to walk-in clinic. They ended up putting in a Foley catheter. 10 days later, that was removed. The next day, I was back at the ER since I could not urinate again. And then I did this again, and now I'm being referred to for a what is it called? Cystoscope.
Cystoscopy.
Yeah, they did a CT and they said there's nothing. The bladder is good. If you remember right, I'm stage 4 metastasized to the lungs, so I've never had any surgery or anything on the prostate. But so don't know if that is the issue or not. And there isn't anything in the bladder based on the CT. Is this common? I've never heard of this kind of urinary retention problem going along with the prostate growing.
There's the tube of the urethra that carries the urine goes right through the middle of the prostate. And so anything that swells up the prostate, whether it's prostate cancer, prostate enlargement, strictures, outside masses pushing on the area, anything that swells up the prostate or interferes with that little tube will cause urinary retention. So the most important thing, once you've relieved the guy's misery from having a half a liter of urine or more in his bladder.
Oh, I made a whole liter before it was
a whole liter. I know. I've heard of something like that. Is to find out exactly what the cause is. Now, if you were 10 days with a catheter in yourself, in that time, did anybody determine exactly what was interfering with your urethra?
No.
It could even be medications. No?
No.
You got a urologist? Do you have a urologist you like?
Yeah, well, that's what is gonna be Wednesday. Is a urologist who does the scoping.
Well, then they'll do the scope, and at some point, as the scope travels up the urethra toward the bladder, the restriction will be noticed. They'll see something squeezing in and getting in the way. And at that point, they may take a biopsy sample, they may just expand it, they may, who knows, they may do a TURP. But hopefully the answer will be available on Wednesday. Do you have the catheter in now?
Yeah, I'm on the third catheter.
Third catheter. Well, it's two more days, which is a long time, but I don't see how this is going to be done without getting cystoscopy.
Is this common though?
Yeah, all men get obstruction of the urine all the time, all the time. It's very common. Maybe not quite so common in this room where a lot of us don't have prostates anymore, but it's a very, very common symptom.
Okay.
And you could probably learn something from MRIs or various scans, but I think you'll have to get that cystoscopy. I dreaded cystoscopies all my life. I've seen them done, and I always dreaded the day that I would have to have one. And then by the time I actually had to have one, it was much less of a pain than I imagined it was going to be because I had built up so much fear about it.
Yeah, I mean, I remember when I had to have one because I had some bleeding and I was so anxious. I don't get anxious at all, but this bothered me. But it turned out to be an absolute bloody nothing. So,
Yeah.
but Mr. Valens, what do you want to say about this?
Oh, as far as the retention, I had severe retention, and they ended up giving me a TURP, a transurethral resection of the prostate, because I had a catheter in for 6 weeks. Every time they took it out, I couldn't pee at all.
Well,
what was the diagnosis in your case? Was it benign prostatic hypertrophy, or was it prostate cancer, or what?
Well, my cancer never expressed PSA. So when I had the retention, they took a PSA test and said, "Oh, you don't have cancer, so we'll just do a TURP procedure." And took 6 weeks till I got the TURP procedure, and then I had 5+4 Gleason.
Yeah.
My cancer hadn't been putting out any PSA, and the rheologist said, "Well, you don't have cancer."
Yeah, I've gone through that, and back in 21, where they did the what's it called, where they go through the artery and with the little BBs because it was quote benign. Well, it wasn't.
So, Richard, let me just check with you. Have you talked to Josh Allen and the other guys about what's going on, or who is treating this?
Right now, Josh Allen is out of town, but I've got message to him and then to Markowski as well. So I should hear back either tonight or tomorrow.
Yeah, well, I think it's really important because you have this very unusual cancer, foamy gland, and the urologists you're dealing with are not going to be familiar with foamy gland. Very few people are, and it may well be that there is a bunch of cancer in the prostate. So I would not be, yes, you probably do need a cystoscopy, but I think you've got to put these urologists in touch with your GU medical oncologist, and they need to come to a decision together. They should not be working in silos.
I agree. Yeah,
that's a good point.
Need to be more aggressive at getting that communication going.
So,
it's so difficult these days to get doctors to talk to each other. I can't believe it. So I'm glad you brought that point up.
Yeah, it arises all the time. I want to keep moving because we're 45 minutes in left, and we've still got.
Okay, that was all the question I had
to touch base with. Jim Thompson, you said you had a PSA report for us.
Yeah, good evening, everybody. I went back to the doctor January the 29th, and my PSA went from 56 down to 0.02.
Great.
And I was talking to the doctor, and I asked him, I said, well, would I be taking radiation? He's going to tell me, so you may not need it. So you may not need radiation. He said, it's only I can tell you that you're going to be on this medication for 18 months. So I said, you sure I don't need radiation? He said, no, you may not need it. So what's up with that? The fact of him telling me that I may not need radiation.
Well, again, is this the doctor at the VA?
At the VA, yes, it is. Yeah.
And is this same doctor that
Stephen Cresno?
Yeah. You gotta give him a hike. That's my view. I don't care who he is. I mean, you know that we you met the enemy, Jim.
Yeah. Yeah.
You met the enemy, and the enemy is us. And you know, this guy, he wouldn't share his records with you. He doesn't think you need. You know, I don't know what sort of scanning he's done, if any. Has he? When you were at 56, did he give you a PSMA scan?
He gave me a PSMA scan, and he found out it was in my lymph nodes, in my chest, and in my back, and that was it. And I said, "What about the Gleason score?" He said it was so small in my prostate that he couldn't get a Gleason score.
Look, there's been first of all, to get the Gleason score, they've got to do a biopsy,
right?
But at 56,
he had a biopsy. Yeah,
I had my first biopsy back in June, and he said it was so small they couldn't detect anything. They couldn't get a Gleason score. He said it was too small. And then the second biopsy was in,
Jim, this guy, what is it that you're waiting for? Is it some clear metastasis until you switch docs? I mean, in December, you told us the guy refused to give you information, refused to give you a referral. Now you've done great. I mean, it's a sign that you will respond very well. And you're saying, well, do I need radiation or not? I would say, I don't know, but if you had lymph, if there was disease in the lymph nodes, I think most docs probably would have given you some hormone therapy and some radiation.
Right.
But the fact is, this guy doesn't know what he's doing. Well, I mean, Jim Marshall, how do you want to? You're the expert with this facility, and you know this guy Krasno. I mean, how would you counsel, Jim?
Well, actually, I prefer to do it within and with the veterans group, because it has to do with how to deal with and with the VA. And it just so happens I am referred out of there over to Channing Powler as of today. So
that's just what we were going to try to do with Jim.
Right.
The other Jim.
Probably how to do all that stuff would probably be boring to the guys in here. But
okay.
Because
but let me ask you the question.
VA, so stay tuned tomorrow night.
Right. So let me ask you a question. Forget how we're actually going to do it.
Okay.
If this were you, would you accept that decision from Dr. Krasno?
Probably not. I don't think I would.
Okay. So, Jim, if my guy, I wouldn't accept it. Jim, who knows the guy, probably wouldn't accept it. I think that, you know, the way that AnCan would navigate you would be to get you another opinion, and where you get the treatment, I don't know, but you need to be, in my view, this guy just keeps dissing you, and he's that old and he's been around that long that he thinks he knows everything, and it doesn't sound like he may do. Now, he may be right, and you may go to Dr. Paller, and Dr. Paller will say, no, since you're responding, it's just fine. But I would want a second opinion, and I think you're right to question, is he right? I think
I want a second opinion.
Right. So I think you've got to push for that. And I get myself out from under this guy. It's just crazy.
Okay. Right. I'm also dealing with my primary at Kaiser too. And he did say that he know the lady. What's her name? Dr. Peller? Oh,
yeah.
Peller, I believe. Yeah. And I got the paperwork to him now, all my paperwork from the VA. He's got it. He said that he would give me a referral to Dr. Peller.
Okay, well, you got to get your act into gear and get that referral.
Right.
So, anybody else want to say anything to Jim before we move on?
Good news about that PSA.
Yeah, it's great. I mean, that's what it's supposed to do.
Right.
What it's supposed to do to get you to there, and let's see how you do with that, and that's the next step for the next few months. And do you need radiation? We'll find out. Okay, moving right along. Thank you, gents, for handling Richard Craymond. Bob Schwartz, we started talking about this a little bit, but Bob's going through chemo. He's having a bit of a rough time with fatigue, with nausea. For those of you who are in this group who have been through chemo, do you have any tips you can give him how to deal with his chemo? Bob, is there anything you want to add to that?
No, that's it. Plus, the only other thing I got is I got a red rash that they've advised me to take 1% hydrocortisone on to try and keep it in check. But it keeps spreading out to different places, like playing whack-a-mole with it.
Anybody, any chemo peeps in here who want to make a suggestion? Any suggestions for or doctor, or any of the doctors, or anybody want to say anything about dealing with chemo, nausea, fatigue, any of this stuff? Jimmy Greenfield.
Hello, Bob. I'm sorry the troubles you're having. I'm familiar. The rashes, I had various rashes. I lost my my ability to keep strong nails, which was important to me for my musicianship. But I also had odd rashes, dry skin, things that would come and go. Like you said, they move around. I cure them in one spot, they come back in another. Mostly those kind of got ironed out. I lost all the hair off my head. Actually, I had already lost it all, so that was that. But definitely fatigue. And like with the radiation fatigue, like with the especially the ADT fatigue, the only thing I knew how to do to attack it was to exercise as much as possible. I always talk about that, but I always throw it in if somebody asks about, because I think for all the side effects, it's your weapon of choice. But I understand if you're too tired or if there's other physical problems. But I always say that. As far as the rest of it, I had nausea, but I found that the anti-nausea medication was very effective. I don't know what you're taking for it, but I only had to use it sporadically. And when I did, it was like magic. So I wonder if you're taking anything for the nausea, or if it's constant or is it occasional?
Not at this time.
I would look into it. Really effective drugs now. Chemo used to be famous for causing really bad nausea and vomiting, and all the doctors know that. And the medications they have now are much better at controlling it. Isn't that true, doctors?
Oh yeah, when they give me the chemo, before they give me the chemo, a half hour before that, they give me a shot of steroid and nausea medication.
Okay.
But that's the only time I get it is then.
Well, they should give you some pills for if it pops up. They certainly did that for me.
Right. I mean, talk to Dr. Guanciale and ask her, tell her, first of all, ask her, do they have a palliative care service to help you with symptom management? You heard our conversation earlier on, so I'm not going to repeat it, but using ondansetron or compazine, or trying yourself with ginger and making up something with ginger, eating those gingins that Luther put in, can work really well, but don't suffer. This isn't about how much you can suffer. I mean, if you've got these issues and you're on chemo, the doctors are there to help you, and they will help you. But you've got to tell them, I've got, I'm living with nausea. They'll give you something. They'll try different things, something gentle. If that doesn't work, something more aggressive. Zofran wasn't so good for Mark. Maybe it works great for you. It worked great for Frank. But these are all guys who are going through this. So I want you to take this message home that the stuff we can do, you shouldn't be there suffering.
I appreciate
Mrs. Schwartz, I know you're listening in. Can you not? You got to do something to get some meds down him to make his life happier.
I will. It's the rash this time. It was his hands. They swelled up, and then it became now this time it's his elbows and his arms. And we freaked out the first time. Thankfully, they told us it was natural or supposed to happen. But it's just the weird things that have happened. It's kind of scary.
Okay, but that Dr. Guanciale is great. She'll listen to you. She's not going to turn you away. You've got to let her know. Len, what do you got to say on all of this?
I think you gave good advice there, Rick. Ask Dr. Guanciale for a palliative care specialist. If you feel she's not doing enough to mitigate your symptoms, because you don't want to stop taking the chemo just because of the side effects, particularly if it's working.
No. And is there anything you can offer advice to, like as far as sleeping? Because like sometimes I want to be dead tired and I'll just lay there before I go to sleep for hours before I finally get any sleep.
Dr. John, and we'll come to you, Frank, in a second. But on the sleeping issue, what do you say?
Are you tired in the daytime because of poor sleep, or do you take naps in the daytime?
No, I'm able to push through it with no problem during the daytime. I can strong through it. It's just at night when I'm exhausted, I'm ready to go to sleep. I lay down and then all of a sudden it's like I just can't go to sleep.
Yeah, and you're not a coffee drinker, are you?
No, I haven't had coffee since I've been on chemo.
Well, one thing good about your insomnia is that it's not causing a lot of daytime tiredness. So you have a long, what might be called an initial insomnia, the amount of time it takes to go to sleep. You still getting up at a regular time in the morning?
Oh, yes.
Yeah. So to bring your sleep onset quicker, you probably need techniques like progressive relaxation or meditation, and you might need even a sleeping pill. But the nice thing is that you're good during the day, so what sleep you're getting is actually doing the job of restoring you. So that's nice. You don't have to worry too much about it. But
all right, thank you.
So let's go to Frank and then Gary, and then I'm watching the time, so we'll move on. But Frank, what's your advice?
So real quick, I just want to say that I do listen, and Jimmy Greenfield mentioned about exercising, and I took that advice, and so I started exercising, and it's really helped me a lot. But the insomnia, I was on sleeping pills. They gave me Xanax, they gave me everything, and I hated that because I don't like it the way it makes me feel in the morning. But I'm sleeping again now, so I've dealt with all of that. So, but I just wanted to say I want to stress the exercise, because that's made a major difference in my life.
Okay, Gary.
Yeah, can you hear me?
Yes, sir.
I was just going to mention I have the same problem, difficulty getting to sleep. And then once I'm asleep, I'm up, 5 times a night. to pee.
Yeah.
So, you know, I was really just getting racked out. I do take trazodone to help me get to sleep, which is nice. As I understand it, it doesn't affect REM sleep, and I wake up, you know, you wake up feeling drug-free. I don't, you know, you don't wake up feeling kind of like you do with some sleeping aids. But the problem I'm having is just the dose that's enough to get me to sleep sort of gives me weakness in the legs, and I'm unsteady on my feet at night. But there are sleeping aids that will not leave you feeling all sorts of drowsy in the morning. Might look into it.
Thank you. Do either of our doctors want, Dr. Jack or Dr. John, want to say anything before we move on that?
You can always write to me if you have questions about sleeping pills, or if somebody, if your doc wants to prescribe one.
Thank you. I appreciate it. And I want to thank the group for tonight for the comments. Thank you very much. You too, Rick.
It's a pleasure, Bob. You tell
My
that
doctor
Dr.
put me on
Guanciale.
trazodone. My doctor put me
Tell
on
that.
trazodone.
Use your hand, Jeff. Don't just jump in.
You were just finishing, and I didn't think.
No, I wasn't. I was talking to him. Okay. I was just gonna say, Bob, tell that nice Dr. Guanciale we're very grateful that she's taking care of you so well. Okay.
I am too. I am too. She's a great quarterback.
She's very nice. She's very good.
Go ahead, Jeff, quickly, please.
Yeah, I was prescribed trazodone, and I only sleep 6 hours a night, and I was drowsy as could be in the morning. Just to comment that I did not feel it was good for me.
Okay. You know, it's the same old story. Everybody is a little different. Right, I'm going to keep pushing through because we're still going to stop by Eric. We're going to stop by Jimmy, and we're going to stop by Steve Lodge. Steve, here's what I want to do, because there's two big discussions with you. Let's take one of them now. If we got time, we'll go to the other one at the end. If not, we'll come back to the other one next week. I'll make sure that Ben's aware of it. I'm going to pick the one that I think is most relevant to you. And this is one that Dennis, I know, has something to say about. Dennis Correa. You're asking us what type of evidence out there is there for changing your hormone therapy regime in some fashion or the other. So if you are on a regime of Lupron and abiraterone, or Lupron and enzalutamide, and you've been on that for a long period of time, which to me is probably between 3 to 4 years, but we've known guys who have been on that for 5 years. We always think, from what we've seen and what we've heard and talking to some of our doctors, that you need to change that routine in some way. Other than just switching the ADT, because there's no evidence that just switching an ADT makes enough of a difference. There are times when switching an ADT has made a difference in the past on monotherapy, but we really don't see monotherapy anymore. So why is it? Because Steve Lodge is saying that the evidence seems to be thin. Why is it that we should change things up and make a change if it seems to be working? So anybody want to make a comment? Maybe it's somebody has changed up or made a switch, or somebody who's thinking about it. Anybody want to put that? Dennis, can I pick on you to begin with?
Yes, you may. I started on this kick, maybe 5 years ago or so. with the need, number one, take the drug holidays when you can, in accordance with your doctor, when you can get that PSA down to not detect or so. Give your body a chance to start building back up again. And then the other thing, there was also a clinical trial, which I never continued to follow, but because it was mostly for newly diagnosed men, where they wanted to change up the ADT drugs that they were given, like every 3 months or 6 months, I think. And this was all to try to keep the cancer guessing about what they had to build up to try to defeat. And overall, it seemed that they were getting a longer life expectancy doing that, following that procedure. So that's kind of what I've kind of intermixed with my drug holidays too. When I come back from a holiday, I'll start back with a new drug. Like, now I'm on the darolutamide, and brings the PSA back down again, and hopefully I'll get back down to non-detect where I can take another holiday. But that's, it's part of my own philosophy, I guess. But there is some science behind it. But it's not an exact one at this point.
Well, anyone else want to say something on this? Steve, you want to say something? Go ahead.
Yeah, I was just going to summarize where I'm at. I started with bicalutamide in December of 2021. Started Lupron in January of 2022, and then abiraterone in February of 2022. And with my current provider, I'm going to have to argue for a change. I might be changing providers, and I was hoping that, and it might not take quite such an argument. But, I do have some heart issues, so I'm thinking perhaps changing those drugs because those heart issues might be one good reason. So I'm just looking for good arguments to use to change.
Okay.
Yeah, Dennis said there was some science behind it, but I'd like to see it. Steve and I discussed this a few weeks ago over emails, and I really couldn't point to anything in the literature.
Well, I did find that interesting article, which needs more than my knowledge to wade through, which was, I think it's pretty much on point. It's specifically about this, which I sent to Dr. John. It's probably on his to-do list right now. But I don't know, Len, what's your thought on this whole issue about staying too long on the same regimen of hormone therapy?
Yeah, from those studies done by, what was it, Armstrong from Duke, where he found that if you were on one of these powerful second line anti-androgens or abiraterone, it was really abiraterone and enzalutamide, that there was a good chance you could develop radiographic progression of the cancer without PSA.
Right. Progression. Good job.
Yeah. So that's the argument behind that. But I'm in Dr. John's camp here too. Like, I'd like to see what Dennis is talking about. I don't recall seeing anything about switching drugs that was successful. They usually say there's cross resistance to the lutamides. Although, as I know, Rick always will say that it's best to start with Abby, and that may be true. But to switch from one androgen receptor blocker to another, I'm not sure that I've seen evidence that that's a successful strategy.
Well, the other thing that we've heard of too is that staying on any one of these things too long may be a possible reason for our cancer to morph.
It makes
Well,
sense.
I mean, that's what I think, and I think this paper that I found supports it. But the problem is that Dr. John and Len and Steve are finding difficulty justifying that in the literature. But Dr. John, that Armstrong study is a great one. I forgot
Yeah,
about
I'm familiar with that, but it doesn't exactly address the point, I don't think. It does address the point that you can have radiographic recurrence without a PSA increase, but that doesn't really help us to say that after X number of years on ABC, you should change even if things are going well and you'll live longer.
Jim Marshall. You addressed this after you'd been on your Abbey for 5 years. What do you got to say?
Something for Steve, okay, and it has to do with how I got to John Hopkins. Okay, on the heart issue, you can play that one on the heart issue because if you look up essentially Abby will cause heart issues, and I already have heart problems, anyway, AFib, etc. Another place to look for the heart issues is on your EKGs because there is a danger of the elongation of the QT and QTC supposedly intervals. And I looked up at mine, and I already have a screwed up EKG reports. So that's a factor. And then I don't know if you've got hypertension essentially outside of the drugs that you take. I do. So I already got hypertension, but I've had it for years, but it was just another thing I could say, well, geez, I need to change to something else or to consider that. And that's what happened to get me out of the VA because I put it down all on paper and I made the argument to the doctor, and I think, and also I have the heart murmur besides, which is brand new from the triple bypass surgery. So all those things together, I think he said, well, geez, he is a little bit beyond me and approved my community care request. Now, I don't know where it will lead except over to Hopkins.
Right. So I guess one question I have for you, Steve Lodge, is have you followed up with that name, that Dr. Effie Anastasio or whatever her name was, that cardio-oncologist that we sent you?
Not yet. I saw my cardiologist about 4 months ago, and I do have another appointment coming up. I was going to see how this pulmonary therapy might help before I went down other roads.
Okay, but you see, here's what I don't get. What are we waiting for? We have a cardio-oncologist. She specializes in heart and with cancer. We don't know her, but she certainly ticks all the right boxes when we listen to her speak. And she's going to understand more about abiraterone and heart issues than your cardiologist is. And if you want to talk to somebody about what are the risks should I stay on this? She's the sort of person we should be talking to. So, I mean, I get that there's always reticence to change docs, but when you've got a doc who's in your institution and you can add to your team, is your cardiologist at UW or somewhere else?
He's at UW.
Okay. Then I would definitely go ask for an appointment with her. She can work with your cardiologist.
Yeah, and I haven't even been with a doctor since that came up to ask for a referral. Or
you don't need to be with the doctor. Send them a message.
Okay.
What the
You know,
hell?
just tell Yastrzemski, you know, you have these heart issues. You really would like to speak with a cardio-oncologist. This person has been recommended to you. You know, can you please see her? I don't even know if you need to get a referral at UW. You may be able to self-refer to her. Call up her office and ask if you can self-refer. You're a patient of Dr. Yastrzemski's, and you're on abiraterone, you've got heart issues, you come in and see her? If they say, oh, sure, you're there. If they say, no, you've got to get it from Dr. Yastrzemski, you'll go back to Yastrzemski. But what I wouldn't do is just sit on it. But that's me, you know, I'm different. Jeff Marchi.
Yeah, neuroendocrine, it was discussed about ASCO talking about the fact that if you stayed on these drugs for more than 4 years that you can get neuroendocrine. I didn't hear that mentioned.
Well, that's the morphing. That's exactly what we just mentioned. When we say morphing, that's code talk for neuroendocrine.
Okay.
Okay, it's the same thing, because it's not true neuroendocrine. True neuroendocrine in prostate cancer is rare. It happens in less than 1% of the people. Morphing in advanced disease happens in about 30% of the people. What they actually call it is small cell neuroendocrine-like disease, because it's not exactly morphologically exactly the same as original neuroendocrine, but it behaves just like neuroendocrine. So they call it neuroendocrine-like. But I thought you were going to tell us your story about abiraterone and your heart.
Well, it definitely gave me high blood pressure. I'm on 3 medicines still because of it. It gave me AFib a couple of times, well, 3 times total. And so I'm off of it now. But better to be off of it when you haven't failed it than to be off of it if you have failed it. That was one of the things that Len had brought up, that once you failed the drug, moving to lutamide is probably not going to work. It's very much lower incidence of having it be successful.
Correct.
So that's another thing to think about when considering staying on it.
So, Steve, I'm just watching the time, and we may stay on a little bit late to talk about the other issue, but is it okay by you if we move on to Eric and then to Jimmy? Okay. Eric, we haven't heard from you in an age. I'm so pleased you're with us. Bring us up to date. What's going on there in that Baltimore DC corridor?
Oh, okay. Well, it's outside of the prostate cancer. It's crazy right now. But so I've been on Argivix and Extendi for, I think this is going on like my 9th month. I go see my oncologist next week. So my PSA has dropped to 0.1, and my testosterone has, dropped to like 15. But I get hot flashes. I tend to sleep better if I exercise at night, like probably like before I go to bed. But sometimes it's hard to do. But I wake up in the middle of the night, usually about 2 or 3 times to use the bathroom, and I have a hot flash like right after that. So I'm constantly tossing and turning. So Um, I was wondering if there's like any like natural things that I could take, to kind of, combat, some of the hot flashes or things like that. Other than that, I feel pretty good. Sometimes, now that soccer's over, but sometimes, I'm out and I just like when I get in bed, like my balls is like, great, you know. But other than that, I'm doing pretty well.
So let me ask you, are you or have you tried the Ember Watch?
No.
Do you know what it is?
No.
Okay. I'm going to try and put it in the chat window for you right now. It is, anybody wearing one right now? Up, there you go. Look at Jeff Marchi. We usually have a bunch of guys wearing them. It is a gizmo that you buy that acts on a particular nerve that senses when your body temperature is going to change. And it intervenes and either warms you up or cools you down according to what's going to be happening. And it has a daytime and a nighttime setting. It does not work for everybody. Len, what percentage of guys doesn't it work for? Do you remember?
Oh boy. Unfortunately, I don't. I don't remember.
Okay, well, we wrote it up recently, Eric. If I remember, I will try and send it to you, but we wrote it up in one of the reminders about 2 months or 3 months ago, right, Len? Was it about 3 months ago?
Yeah. I think it was 65%, Rick, in that neighborhood.
It didn't work for.
No, it did.
It did, yeah. It worked for the majority of guys. It can be a little expensive, although I think you can get them now from Costco and Amazon. I think they're about $300, and that would be my first port of call for you, because if it works, you're going to get a great night's sleep. Is there anybody? We'll check with Jeff, and first of all with Jeff, and then if there's anybody else who has used an Ember Watch successfully, put your hand up. Jeff Marchi.
Yeah, the night ability was the best for me. I used to wake up at night and my sheet would be soaked under me. I'd have had 2 or 3 hot flashes during the night, and it just stopped it. A couple other things. Somebody on a couple of different places said just eating tofu regularly works. Acupuncture is supposed to be very successful.
Yes.
For many people, but not for everybody. But it's the night capability of this thing. And by the way, they've been selling them for about $210, $220 at Ember this week, I think it is. And they also have a 60-day money back guarantee. So if you try it and it doesn't work for you, but I've got one of my buttons. There's 2 buttons. I've got one set for daytime. If I get a flash during the day, gives me 5 minutes of cooling. You can have more if you want. And the other one I have for night, so that if I'm in bed and I start getting hot flashes, I just click that and then they go away. It really works well at night.
Now, and I thought that there are also some chemical solutions, but we don't like chemical solutions so much, which I thought Mr. Markey was going to mention, but he was very good and he didn't.
Depo-Provera was fantastic when I was just on Lupron. It was every 3 months a shot, and just it ended my hot flashes, and I had a lot.
Okay, so Neil Sundstrom, did you want to talk about hot flashes?
Yeah, I used the Ember when I was using Orgovix, and it worked extremely well. I got my brother one, and it works for him too. I mean, we're part of the 65%.
Okay. We think it might be higher. I'm going to have to go back and find that reference that I put in. Jim Marshall, what do you got to say?
Let's see. During the time anyway, I was having them. I used to sleep with a fan pointed straight to my face. I don't care if it was the summertime, wintertime, fall, spring, but it was blowing on my face, directly on it, and it seemed to calm them down.
Eric, are you taking notes? Are you looking at the chat window? I'm trying to put stuff in there for you.
I am looking at the chat. I see it, the Ember Watch. I see it.
You know, I try throw a couple of $100 at it. I'll tell you what. Either you can send it back within 60 days, or if you forget to send it back within 60 days, you're going to have a guy on here who comes in sometime soon and is going to want one, and you can make a deal with him. Luther, what do you got to say?
The oxybutynin has really worked for me. You know, I can still get kind of hot, but I'm only taking one a day, and you're supposed to take two, and I don't wake up hot.
Yeah, but hold on a minute. That's only if you're on abiraterone.
Yeah, I think it doesn't work on the eye drugs, right?
Doesn't work on the eye brothers. But it's a good solution. It's a good suggestion, a very good suggestion if you're on abiraterone, for sure. Anybody got any other suggestions for Eric? Or that we giving him some homework? And I would try all of those. I would try anything before taking a Depo-Provera or Megace or one of those. You know, the acupuncture can work, but it doesn't last that long. But I think I'd try that Ember Watch for the first one. Now, I have another question, which is actually a segue for me, which is you had an enlarged testicle, I have in my notes. Did that go away?
Well, no, it did not go away. It turned out that it was a cyst, and I go back to my urologist in May, and possibly discuss, you know, maybe having it removed or what's the next step. But
okay,
I did have a PET scan, and it didn't show any signs of any cancer or anything like that.
Now, my records say you're in Glen Burnie. Is that right?
Yes, sir.
And how far is Glen Burnie from the very north end of Washington, D.C.?
Probably like an hour to an hour and a half.
So, like, if you drove 45 minutes and our next participant drove north about 45 minutes, could you guys get a cup of coffee together?
Sure.
Jimmy, you're on.
That's not fair. He didn't know who it was. Now they know it's me. He's going to run as far as he can. My brother lives in Annapolis. We'll get together when I'm over there. He lives right on the bay.
Oh, okay. Yeah, sure.
We'll set up there. How far is Annapolis from Glen Burnie? Not far, right?
Not far at all.
We'll get together.
And wait a minute, yeah. Eric, you ain't heard nothing yet. Why am I suggesting you meet with Mr. Greenfield? Go ahead, Mr. Greenfield.
Oh, because I just had hydrocele surgery. Hydrocele is just a fancy name for a larger cyst, I believe. It's a fluid-filled sac in your testicle. Big balls, Eric, but not the good kind.
Yeah.
So we're going to work on that. So that's what I'm supposed to talk about. First of all, Jim Marshall, man, the fan. The answer, my friend, is still blowing in the wind. That's what I have to say about that. But that's enough funny talk. What I want to say is I'd rather you go to Steve L's Other Matter. My situation took kind of a bad turn today. It's pretty involved now. It's a little discouraging, but it's not life-threatening. It just sucks. It's involved. I have to explain it a little bit. I don't want to do it at the end of the meeting. So if you can move me to next week, I'd be a little more comfortable if that's okay, boss.
Okay.
You'll also know a little bit more by then.
Okay, you might also know a little bit more. Well, I'm just sending a message to Len and Eric, as you well know. Eric, can you email Jimmy your contact details, and Jimmy will email you back his contact details. Save me doing it later to the two of you. Is that okay, guys?
Sure.
Definitely.
Okay, great. But listen, Eric, if nothing else, having a coffee with Jimmy is very entertaining. So, you know, it shouldn't be a total loss, even if you want to speak about things other than big balls. All right?
Moving right along. Go ahead.
And Jimmy, I'm sorry, I'll check in with you later tonight or tomorrow to find out what's going on. The other, it's right on 8 o'clock, so I'm going to take a little liberty and we will raise this other issue. The other issue that came up with Steve Lodge, and it came up last week, which is sort of why I want to bring it up, is that when you get bills from your provider, and they cite what they are billing, the amounts they've been billing for, sometimes from under Medicare, sometimes not under Medicare. In my case, it was under Medicare. In Steve Lodge's case, it was under Medicare. Those numbers, most of the time, are purely fictitious and bear no resemblance to reality. That's been my experience. It's also why we have no idea what these drug companies are getting reimbursed, at what rate they're getting reimbursed for by from Medicare, because it's all kept under their hat. They don't release those numbers, but they throw a number onto a piece of paper which they give you, which is totally unrelated to what's actually being paid. However, the number that's thrown out there is used to calculate your 20%. But your 20% may finish up being more than the payer is actually paying Medicare is actually paying the payer. So to take a case in point, I think we were talking about the PSMA scan last week, and again with Steve Lodge. Medicare says they'll pay $8,000 or $9,000 for that test. We know you can get that test for about $3,000 or $4,000 if you walk in and pay or cash. So the payer, the insurance company, goes back to Steve Lodge and says, I want to claim 20% of that, which is $1,600. Now, depending on where he is with his plan, he may pay all of it, he may pay a part of it, but that's where this $1,600 comes from. It's 20% of $8,000. How much did Medicare actually reimburse the payer for, or charge the payer for this drug? It was probably less than $1,000, $600 or $700. So they're actually making money off of Steve's payment. You know, Medicare says we're going to charge you $600 for this procedure. The payer pays them $600, but they tell Steve that he's got to pay $1,600 because that's 20% of this Medicare price. It's a game. Most of us are aware of it. But what we don't really want to be talking about in this situation is that we've had millions of dollars or hundreds of thousands of dollars of treatment. I mean, I think from memory, I think I actually have the bills if I went dug them out. Back in 2008, I think that UCSF showed me that the amount that they were charging was like $400,000 or $500,000 for my 25 odd treatments. That's nothing like what Kaiser paid them for it, or they got reimbursed. So, you know, Wes says my PSA via UCSD was $34,000. That's what they told you. That bears absolutely no reality to what your payer paid. It may have had something to do with what you reimbursed. We should not be throwing these numbers around. They're bullshit. They're bullshit numbers. You can go get that PSMA test for $3,000 or $4,000 if you pay all cash. But that's what they use. I think this was the discussion with you that we had last week. But they're not accurate numbers. Eric, did you want to say something on this?
Well, yeah, it was something similar because when I just had the PSA scan, I was going to go to Johns Hopkins because my oncologist is at Johns Hopkins. But then they said, my insurance said that Johns Hopkins for imaging is out of network. But for oncology, they're in network. And if I was to go do a PET scan at Johns Hopkins, it'll cost like $2,500 out of pocket. But they sent me to, I forgot the place that I got the PET scan, and it was like $450 out of pocket. So it's like the insurance company, how they play these, play these games. Like, you're in network here, but you're out of network here, and it's crazy.
What we know is that when they come up with these, for any procedure, when they come up with these ridiculous numbers that the provider sends to the patient, they have absolutely no relationship to what the payer is actually paying. All they're doing is building this up so that they can charge the non-Medicare portion, the 20% that's non-Medicare, they can charge the highest amount. This is if you're a Medicare patient. If you're not a Medicare patient, everything's negotiated the same way. But you can don't rely on those numbers. Anybody else want to say anything else on that? Gary.
Well, the obvious question, it seems to me, is because I just paid out of pocket about $500 for a PSMA that was, my piece of what they said was about $8,900. So,
right.
Given that it's all horseshit, what do we do about it?
Yeah, I mean, so the $8,900 is right around what Medicare prices PSMA scans at. So they can charge you up to they can charge your company $1,600, and your payer can charge you whatever your share of that $1,600 is. What do we do about it? I don't know, because that's a whole issue around Medicare reform. It's around private payer systems. I don't think you're going to get a PSMA for much less than $500. Whatever system you work on, certainly a cash payment isn't. It's going to be probably at least $2,500 to $3,000. You might get it less now because they're more competitive. But I don't know. I mean, anybody have any suggestions on what we do about it? I just wanted to make you aware that we should not be going around talking about these numbers that we see in these bills, because those numbers are total.
Right.
Len, you like this subject?
Insurance? I hate insurance.
I know you hate it. That's what I'm saying. You must have something to say. It drives you nuts with all these ridiculous prices they come up with.
Yeah, absolutely. I mean, I have Aetna as a secondary payer to Medicare. They claim that they'll pay 90% of what Medicare doesn't cover, and yet somehow I see what they pay, and then I get billed the exact same amount. So it's more like a 50-50. They've never been able to explain that to me.
No. And the reason is because all of these numbers all of these negotiated payments are guarded very closely, held very closely to their chest. And it's one of the reasons why the insurance companies totally oppose these negotiated prices that the Biden administration came up with at the end. For now, I don't know how many, 20 odd drugs is it? There was 10 or 15 to start off with, and they added another 10. But nobody wants these prices known. Now they can't charge more than these negotiated prices. Except now this administration is probably going to get rid of those. I've heard them talking about getting rid of these negotiated prices because the emperor's making some money off of I'm sure he's got some deal with one of the pharmaceutical companies. And
they already did it.
Yeah, I think they're rolling back.
They already did it.
Price
they're rolling them back
to negotiate with Medicare. I think they roll that back.
Yeah, that's right. Well, and why? Because God forbid we should have transparency in the system. You had transparency, you can't make deals.
Yep.
And somebody told me, one of our own peeps told me, who happens to be right now reluctantly on the inside, that there's a certain person making deals left, right, and center. And I'm sure this person's correct because he's seeing it. But if everybody knows what the price is and that's what it's going to be, nobody can make a deal. Nobody can take advantage of the system because it's no longer negotiated. It's set. It's a set price. So, we've rolled back these costs. We're all going to be paying a little bit more, and there you go. And yeah, it's Wes talks about medical tourism. Yeah, but I don't think you're going to get it less with medical tourism. I know what, like with Pluvicto, what people charge. Dennis Correa.
Yeah, Rick, has anybody heard anything about the $2,000 max for Medicare drug Part D annual $2,000 max?
I have heard nothing. As far as I know, it's still good. But has anybody else?
Well, I just
it's still good.
It's still good. Second month of the darolutamide, Nubeca, and it was free because I paid the first right up the first one last month. Paid the maximum.
Right.
I hope.
I don't know. We're going to make this the last comment because we're now close to 15 minutes. But close us out, Brian. What did you want to say?
Yeah, I have a Medicare coach, and he'd be happy to join this group if you guys have any Medicare questions. But if you have Part D, indeed, it went from $8,000 out of pocket to $2,000 for 2025.
Right. No, that we know. I think what Dennis is saying is we know that. I think Dennis is saying, is it going to stick or is that going to get rolled back? That's the question.
Oh, I don't have a crystal ball, and I didn't sleep at a Holiday Inn Express. I'm at a Marriott Residence Inn.
Well, we don't know either, but yes, we know, and we've written about it. If you go to our blog, we've written about the $2,000 and a couple of what you choose. But I think Dennis raises a very good price. Who's to know whether they'll roll that back next year or not? Don't know. And on that cheerful note, that very cheerful note, I'm going to say my pasta sauce calls, and I'm going to close it out. Anything else anybody wants to say before we shut out?
Buon appetito.
Thank you. I was because Dr. John's left. Good night, everybody.
Hopefully your sauce is not burnt.
Thank you. Me too. Goodbye.
Later.
Good night. Good night.